please. Yeah, let's continue. Sidra, start reading.
Central retinal artery occlusion.
Central retinal
Artery occlusion.
is the door closed? Stop. Continue. Don't move.
Symptoms. Unilateral.
Central retinal artery occlusion. Let carry on. Are you listening to the first time in your life? You heard something about it? Thank you. Changing the doors for time. Thank you. Nandi. Nandi correct है मलयालम. आरे बड़े नंदी परियोजना.
Thank you.
ना?
Thank you.
Yeah. This is thank you. आरे thank you for you. We come to the doctor. Maybe one or two patients say thank you. How do you know?
Yeah, for each other.
I mean, everybody is polite here. Good manners, but I don't know why thank you. You would excuse me for him, right? What about a friend out?
Yeah.
Excuse me. Is it like a bad already? When if somebody is sitting in front of you, excuse me, you go, right?
Yeah. Just give a straight shake.
Yeah, you go straight. It doesn't like scolded the person. Malayalam എന്താ പറയാ? Don't move എന്താ പറയാ? അനക്കരുത്. Move. അനക്കരുത്. Maru. Is it an easy word? Everyday word?
Maru.
Idra ode maru. Onnu maru. Come on. CRAO.
Symptoms. Unilateral. Painless. Acute vision loss.
Unilateral.
Painless.
Why are you reading so fast? Go on, Baba.
Symptoms. Unilateral.
Okay. ഇതൊക്കെ മനസ്സിലാവും.
Unilateral.
എന്താണ് കാരണം? അവിടെ ബയലാറ്ററൽ എന്ന കാരണം ഫസ്റ്റ് വേർഡ് അവർ യൂണിലാറ്ററൽ പറഞ്ഞിട്ടുണ്ട്. അത് നിങ്ങൾക്ക് സ്ട്രേഞ്ച് ആയിട്ട് തോന്നിട്ടില്ല? CRAO, CRVO. Never ever it is bilateral. ഏതെങ്കിലും സ്ഥലത്തിലെ രണ്ട് കണ്ണ് പെട്ടെന്ന് കാഴ്ച പോകുമ്പോൾ അത് CRAO ഉണ്ടാകില്ല. അവിടെ എന്തോ ഒരു സെൻട്രൽ ആയിട്ട് കോർട്ടിക്കൽ ബ്ലൈൻഡ്നെസ് നടക്കുന്നുണ്ട്. ഓക്കെ, ഇതെന്താണ്? ബ്ലഡ് വെസൽ അവിടെ ക്ലോട്ട് ബ്ലോക്ക് ആണ്. രണ്ട് ബ്ലഡ് വെസൽസ് രണ്ട് കണ്ണിലെ ഒരേ ദിവസം ഒരേ മണിക്കൂറിൽ exact same time block or it's close to impossible. Okay, so unilateral has to be the number one keyword. Engane choikkiya, what is the most common cause of unilateral painless loss of vision in eye? CRAO. Okay, CRAO. That should be on the typical. Adana adinde. Okay, then next.
Painless. Acute vision loss. That is counting finger to light perception in 94% of the eyes.
Yeah. Okay.
Occurring over seconds. May have a history of transition vision loss, transient vision loss, amaurosis,
fugax. The thing is, look at how bad the vision has gone. within 3 seconds, patient was perfect, PL plus or counting fingers. It's essentially like his life is destroyed. Okay, the CRAO is taken very very seriously, and the patient comes to you running very very fast. In this case, the advantage of this is some or the other eye hospital he immediately goes, so you don't delay the thing because vision is very prominently it is decreased. Continue please. Why it is important that they come running to the hospital? It will come later on.
So what is MRS?
America's field access.
Restriction in certain cases.
What is ophthalmic region? Ophthalmic region. That's not America's field access. America's field access. See, field access means curtain. Amaurosis means amaurotic pupil. The kind of curtain that causes loss in vision. Okay?
Painless temporary.
Painless temporary loss in vision. If you understand the word, you'll never forget. Like how she said, restriction in eye movement, something like that. Fusion means curtain. Parda on the never a curtain. What do you call curtain? Curtain on the curtain in a Latin name is fusion. So it's like a curtain is falling in front of your eyes, but then curtain is going back up again. So petine black or petine white avan chance within 1 minute, 2 minutes, sometimes for half an hour also. Okay. Matte idane condition mapping half an hour catch up adine catch up ircho it's migraine. Migraine is another transient obscuration loss of vision. പക്ഷെ അവിടെ എങ്ങനെ ഉണ്ടാവും ഡിഫറൻഷ്യസ് എങ്ങനെ അവിടെ പെയിൻ ഉണ്ടാവും ഇവിടെ പെയിൻലെസ് ആണ് ഓക്കെ പ്ലീസ് കണ്ടിന്യൂ
Signs.
ക്രിട്ടിക്കൽ സൈൻസ് നിങ്ങൾ പറയില്ലെങ്കിൽ 0 അല്ലാതെ 0 ക്രിട്ടിക്കൽ സൈൻ വളരെ ഇമ്പോർട്ടൻ്റ് ആണ് ഒരു ലിസണിങ് അമിന കേട്ടിട്ടുണ്ടോ ഞാൻ എന്താ പറഞ്ഞത് ഡോണ്ട് ആസ്ക് ക്രിട്ടിക്കൽ സയൻസ് നിങ്ങൾക്ക് മനസ്സിലാവില്ലെങ്കിൽ അല്ലെങ്കിൽ പറയില്ലെങ്കിൽ 0 ആണ് the whole half an hour has been wasted, 1 hour has been wasted. You have to understand critical science and you have to understand management or the investigation and treatment. If you don't know these 3 things, then it's useless. Everything else is there to understand to better you to make your advance. But without taking these 3 things perfectly, in every disease you will get a 0 from it. Okay? So critical science, please.
Superficial opacification or whitening of the retina in the posterior pole.
Our retina white are.
Whitening of the retina.
Just have a look at that. No, you can look at your own appointments. Just have a look at that. Huh?
Yes.
But it's yellow, right?
Pale. Pale.
Dina. Move. Sit down. Yeah. How do you yellow? That's white.
Pale.
So the whitening is there. What they mean by the whitening is paleness, discoloration. Okay? Don't get confused. First year 50s kids are confusing at your they don't know how the normal retina looks. They look at that, they think it's absolutely normal. I can know it's a nightmare. Like that day when I told you OCT, like looking at the potato or the tomato in black and white, better on potato also. But after the training, you will also able to understand normality and normality. And then I have seen 5,000 images of fundus, so I immediately know that is abnormal. So it says whitening, but actually it means pallid. So it's very very pale. Look how pale it is. Okay. And what is in the center over there? Okay, keep reading.
And a cherry spot in the center of the macula.
Cherry red spot.
Cherry red
You
spot.
skip so many words in there. And
Cherry red.
cherry red spot. If you
Maybe
don't
some-
say this word in CRAO, even if I'm not your examiner, Even if you are getting exam in Australia, Germany, I will catch a flight and come there and give you 0 and 1. Cherry red spot is the biggest keyword in CRAO. Okay, next please.
Other signs may be RAPD.
Me.
Oh shit.
When I lie, you need glasses.
No.
You're thinking about
Marked RAPD.
you're okay with the hip, right?
Yeah.
Have you taken any special medications? Okay, marked RAPD. One point in the importance of dog.
Marked RAPD.
Marked RAPD, then importance of dog.
Pupil.
Yes, it is.
Autism.
Okay, marked is important, she is saying. I am asking, tell me one more condition. Tell me any condition. Where the optic nerve, where is the optic nerve involved here? CRAO, right? Optic nerve into ending సంబంధం ఉందా? Optic nerve అంటే తీరే సంబంధం లేదు. Optic nerve 100% working. How the hell is RPD happening there? CRAO is the only condition along with CRAO where optic nerve is perfect. సాధారణంగా మనకు ఆప్టిక్ నర్వ్ ఉండేది, ఆప్టిక్ న్యూరైటిస్ ఉండేది, TOI ఉండేది, కంప్రెసివ్ ఆప్టిక్ న్యూరోపతి ఉండేది. పెట్టిన RPD, optic nerve, RPD in the This is the only two retina conditions where you have RPD. Okay? बाकी either condition RPD നമുക്ക് ഉണ്ടാവില്ല. Only two retina conditions. So what are some retinal conditions where you see RPD? CRS here. Okay. Next please.
Narrowed retinal arterioles.
അവിടെ ഉണ്ടോ? Retinal arterioles narrow ആണോ? Huh? Confirm ചെയ്താൽ മതി. The booties undo undile. Yes, it's there. Look at this, so thin, like hair.
Yeah.
It's going away. Okay, next.
Box scarring
Box scarring or segmentation of the blood column. Adunda segmentation undo. Train tracking, train into putty box undo. Yes. Because you guys are more creative than boys, more artistic. You're not able to see train tracks in that, like small trains.
Yes.
Other than that, box carrying, okay?
Occasionally.
One minute. Yeah, occasionally. These are train tracks, okay? Box carrying. One train, second train, every engine on it. This is Thrissur like a power. Yeah. Why are there no trains in Kerala? No matter. ఏదైనా సమస్య విధాయించలేదు. Yes, you can.
Trains in Kerala.
I know. Where is there a train? Do you know that Saudi Arabia, you know? Saudi Arabia, India railway network portfolio. Okay. അവിടെ 3 major railway networks. India എത്ര ഗസ് ചെയ്യാൻ പറ്റും? 3,000. India 3,000. India is the most densely connected country with railway stations as compared to any other nation on earth. But the most least dense connected through railways is Kerala. It is far more likely that you will take a bus or a train or a car to Tandoor rather than a train or to Calicut. And from Panithamula, if you have to go to someplace, you have to go to Solapur by car and then take a train. You will the connectivity whatever. I think the reason is because it's a hilly region. Hilly region, I think the ask of the Britishers is that put the construction site. So Chennai is Deccan Plateau, all those places are plains. Maybe other reason. So there is not many trains that can go to Thrissur. Let's see a train. Yes, please continue.
Occasionally, the retinal arteriolar emboli or cilio-retinal artery sparing of the fovea is evident.
Okay. I'm not disappointed. ഈ പോയിന്റ് മനസ്സിലാവും. സംടൈംസ് ഇവിടെ ഒരു സ്പെഷ്യൽ ആർട്ടറി ഉണ്ടാവും. ഇവിടെ ആർട്ടറി ഇവിടെ ഇല്ല, ചിലപ്പോൾ ഉണ്ടാവും. ഓക്കെ, sometimes you have an artery, okay, very very rare. ആ ആർട്ടറി ചിലപ്പോൾ God ഇവിടെ വെക്കാം for some lucky people. How many people will have that artery? If 100 people are there, how many people have that special artery? 15. Okay, 15% of people will have this artery that directly supplies to fovea. So central retinal artery ഇവിടെ നിന്ന് ഈ വലിയ ആർട്ടറി അതാണ് സെൻട്രൽ retinal artery, not that വലിയ artery. This is vein. ഇതാണ് ആർട്ടറി. ഞാൻ എങ്ങനെയാ പറഞ്ഞത്? ഞാൻ അത്ര കോൺഫിഡൻറ്റ് എങ്ങനെയാ പറഞ്ഞത്? ഇതാണ് vein, ഇതാണ് ആർട്ടറി. Yes, 1.3 times more thicker than the artery. So look how thin it is getting there. ഇത് 1.3 times ഇല്ല, almost 6 times thicker ആണ് ഇപ്പോൾ. പക്ഷേ ഈ CRAയുടെ മുമ്പ് ഓൾമോസ്റ്റ് സെയിം സൈസ് ആയിരുന്നു. ഓക്കെ, അത്ര അതാണ് ആർട്ടീരിയോളർ നാരോയിങ് പഠിച്ചില്ല, അത്ര നാരോ ആയി. ഓക്കെ, സോ ദിസ് തിങ് ഈ സെൻട്രൽ റെറ്റിനൽ ആർട്ടറി ഇവിടെ ഒരു ബ്ലോക്ക് നടക്കുന്നുണ്ട്. ഇവിടെ ബ്ലോക്ക് ഉണ്ടെങ്കിൽ കുഴപ്പമില്ല, ചിലപ്പോൾ സിലിയർ റെറ്റിനൽ ആർട്ടറി ഫോവിയോലക്ക് സേവ് ചെയ്യും. You guys know right, fovea is the most important. ഇതെല്ലാം ഡിസ്ട്രോയ് ആയാലും പ്രശ്നമില്ല, പക്ഷെ ഫോവിയ ഡിസ്ട്രോയ് ആകുമ്പോഴേ പ്രശ്നമാണ്. Legally blind. This whole thing is perfect. This one thing is gone. He's legally blind. Okay. This thing is gone. This thing is gone. He's obviously blind. Blind in every aspect. So sometimes for people with severe retinal artery, there is still hope. They have perfect central vision. But when you look, their eyes, it looks like this whole picture is pale retina, but central retina is perfect, like a normal retina. Can you see that there is slightly like a watery feeling here? Yeah? It's something like a small tracing paper you put in water and it's taken off. Yeah? It feels like small watery, smudgy feeling. And then because the moment there is no blood in the whole retina is asking for blood. And they are getting panic. In the panic there is small inflammation of the whole retina. So inflammation causes edema. So retinal epithelium layer is slightly edematous now. That edema is making it look like a watery water. Okay, so this ciliary retinal artery is not here. Okay, this is a normal CRAO. So it is called as central retinal artery occlusion with ciliary retinal artery patent, or central retinal artery occlusion with sparing of the fovea due to ciliary retinal artery patency. Yes. Oh, some unlucky guy will have perfect CRA. He will not have any issue with central retinal artery. In that way, the ciliary retinal artery will have a block. The whole retina is perfectly working. The small place of retinal artery, he will have a block over there. That's highly important. So, these are concepts. This is are you like? That's the next time you come late, I will take chocolate from you. If visual acuity is
visual acuity is light perception or worse, strongly suspect ophthalmic artery occlusion.
Okay. So I'll tell you the story. എന്താണ് അതിന്റെ സിഗ്നിഫിക്കൻസ് എന്തെങ്കിലും സ്ട്രേഞ്ച് ആണോ? ഈസ് സ്റ്റഡിങ് എനിത്തിങ് സ്ട്രേഞ്ച്? എന്തെങ്കിലും വ്യത്യാസമായിട്ട് ലൈൻ ഉണ്ടോ? Till now you have understood everything. And last line എന്തെങ്കിലും വ്യത്യാസം?
Subdimensional period occlusion is more effective. It is most likely because of artery occlusions.
This is also artery occlusion. Ophthalmic artery. ophthalmic artery. Okay? Ophthalmic artery is different from central artery. Don't confuse the same. The both the things. Ophthalmic artery is the big pipe through which the central artery is going. Central artery is coming. Imagine there is ophthalmic artery occlusion. No central artery, no central artery, nothing. The main pipe is blocked. That's the thing.
In that case, the light perception.
100% there will be no vision at all. സാധാരണയായിട്ട് ഞാൻ ഇതുപോലെ PL മൈനസ് I അങ്ങനെയാണ് കണ്ടിരുന്നത്. CRAO, CF 3 meters, CF 2 meters, പെട്ടെന്ന് CF 2 meters. PL minus ഞാൻ ഇതുവരെ CRAO കണ്ടില്ല. പക്ഷേ he is saying PL minus suddenly happens. Think about ophthalmic artery.
Differential diagnosis.
From next week, Fatima will also be on leave. Yeah.
Differential diagnosis. Acute ophthalmic artery occlusion.
Differential diagnosis, acute ophthalmic artery occlusion. Differential diagnosis. Yeah. Makes sense, right? നമുക്ക് CRAO ആയിട്ട് നമ്മളുടെ സസ്പെക്ഷൻ ആണ്. പക്ഷേ it can be ophthalmic artery occlusion also.
Ophthalmic artery occlusion.
അല്ലേ? ദിന വെരി ക്വയറ്റ്. മനസ്സിലായില്ലേ? സിമ്പിൾ പാർട്ടാണ്. പക്ഷെ അതിൽ നോ ചെറിയഡ് സ്പോട്ട്. The entire retina appears white. എത്ര നല്ല പോയിന്റാണ്. If there is no cherided spot, you should always think in your brain. You should always keep on thinking. If I am saying even in migraine also there is transient obscuration of vision. So your brain should think, then how can we know that this is migraine or this is CRAO? Then she told there is pain in migraine. But common sense answer illa samatundam. Acute ophthalmic artery occlusion in a CRAO only difference illangi there will not be a differential diagnosis. But because there is some difference, they write differential diagnosis idana. Second idana. Idu undengil idu undagiല്ല. Idu undengil adile idu undagiല്ല. Idu undengil adile extra addition idu undagiല്ല. Angane it's always like a Sherlock Holmes. You know Sherlock Holmes?
Yes.
Do you know the story I'm about to tell? So in University of Edinburgh, there was a guy called Sir Arthur Conan Doyle. Okay? He's the guy who wrote the famous Sherlock Holmes books in the Jurassic Park series. He was an ophthalmologist. He's an ophthalmologist. The course I'm doing, the MS course, if you do very well at it, you actually get a Sir Arthur Conan Doyle award. But he was a very bad ophthalmologist. Why? He was thinking of stories all day. What do I write next? Dinosaur, detective story, romantic story. ഒരു ദിവസം ophthalmology ഒഴിവാക്കിയിട്ട് പോയി. ഒഴിവാക്കിയിട്ട് കണ്ടിട്ടാണ്. He left ophthalmology. ഒഴിവാക്കിയിട്ടാണോ ഒഴിവാക്കിയിട്ടാണോ? ഒഴിവാക്കിയിട്ട് പോയി. He wrote a small book. It became very famous, and that is how Sherlock Holmes was born. So for years and years on end, people asked him, how did you get a Sherlock Holmes character? He's having a very detective mind. And then a character idea ophthalmology investigations angane cheyidittundayiru aa samayathu. Yeah, that's where he got the bug of this investigative idea. Aa samayathu OCT undo, FFA undo, fundus photography undo. Just നമ്മൾ ITD ഇങ്ങനെ നോക്കിയിട്ട് ഓക്കെ അവിടെ ഹോളിൻ ഹൗസ് ബ്ലാക്ക് CRAO ചെറിയ സ്പോട്ടാണ് അങ്ങനെ ഒരു ഡിറ്റക്റ്റീവായിട്ട് വിചാരിച്ചിട്ട് അവർക്ക് എല്ലാ ഐഡിയാസ് കിട്ടും. നോ അതർ specialty in medicine has this advantage of where you can think like a detective and get all the correct answers. Such a nice specialty we are doing. So you should always be thankful to this. So just think about this. If you say a ophthalmic artery occlusion, there is a reason why he's saying that, because there is no cherided spot. If there is a cherided spot, then it is
CRAO. The entire retina appears whitened.
okay. Next.
The treatment is same
Next.
as for preferences.
Okay. First diagnosis is ophthalmic artery.
Second, commotioretinae.
Commercial.
Commotioretinae. That is retinal whitening from intracellular edema.
Commercial retina
The retinal whitening from intracellular edema and fragmentation of the photoreceptor outer segments.
Are you able to understand what you're doing? Why are you going so fast? Commercial retina, retinal whitening. Okay? From intracellular edema. So far we are just like CRO. Okay? And a fragmentation of the photoreceptor outer segments and RPE. ഇതിൽ എല്ലാ കാര്യങ്ങളും സെയിം CRO പോലത്തെ. In CRO also there is photoreceptor loss. In CRO also there is whitening. In CRO also there is intracellular edema. So how do you know how is this different from CRO? The immune symptoms പഠിക്കുമ്പോഴേ നിങ്ങൾ എന്തായാലും CRO പറയും. Right? Then I will say there is no cherry-cut spot. What you will say? Ophthalmic artery. But then I will tell you, this was after trauma. When somebody is hit very, very badly in the eye with a ball, it's called Berlin's edema or commercial retina. What happens is there is water inside the whole retina because the whole retina is disturbed now. When a trauma is or disturbance not get or vellum cut. Edema post trauma is called commercial retina. It may sometimes have a cherry-red spot also. But very difficult. Huh? Imagine if I tell you all the symptoms, except the blunt trauma part, and there is cherry-red spot also. What do you think? 100% you are very able to see. You will not. The most intelligent alien dinner, nobody will be able to tell. It is not commercial. Except when you ask the patient about his trauma. Post-trauma CRO like symptoms with cherry-red spot. Close your eyes, commercial retina. Or Berlin's edema. What is Berlin? It's a CT scan. Where it is? Confusion. Okay. Continue, please.
Follows blunt trauma.
Okay, fine.
Resolves spontaneously.
Fine, next.
Other causes of cherry red spot is taste sacs.
Now there is some guy in your OP. He's having retina, obviously. And he's having a cherry red spot also. What you will think? 100% you will think CRO. But no history of trauma. Then what else? Yeah. Doesn't have any defected vision. That's the most important point. Then he will have, it's not a CRO. Then it is called Tay-Sachs disease. What is Tay-Sachs is beyond your salary. So forget it. Then Niemann-Pick's disease. Okay? Okay, Kutis. So if somebody asks you, they 100% they will ask you. You will never ever in the history of your life, I can guarantee, you have a patient who's come to you with Tay-Sachs or Niemann-Pick disease. Okay? In Dubai, in Germany, wherever you are working. Especially as an optometrist. Even as an ophthalmologist, even I might not see them. But you will get CRAO cases. And in the Viva, there is a high chance you might get a CRAO case or a CRAO picture. They will ask you, mark my words, where else do you see cherry red spot?
Commercial.
Okay, sure. Smart answer. Okay, doctor, cherry red spot. The strange thing is I don't even like chocolates. I have to eat so many chocolates. Cherry red spot. Here is the condition of now. എന്താ പറയാ CRO ന്റെ ഓൾറെഡി പിക്ചർ ഉണ്ട്. ഇത് CRO ഡയഗ്നോസിസ് ആണ്. വൈവ ചോദിക്കും വേറെ എവിടെ നമുക്ക് കാണാം. ഓക്കെ ഫൈൻ കോൺസെപ്റ്റ് നല്ല ആൻസർ. മറ്റേ ഈ രണ്ട് ഡിസീസ് നിങ്ങളുടെ ലൈഫിൽ തീരെ ഉണ്ടാവില്ല. You will never have to deal with it. പക്ഷേ the only time they will ask you or you will have to tell the answer is when you are talking about a CRO and they ask you about a second place where you see a
cherry red spot.
another disease like Washer's disease, sphingomyelitis, galactocerebrosis deficiency. പക്ഷേ നിങ്ങളുടെ കേസിൽ ട്രേസാക്സൻ നിങ്ങളുടെ കേസ് മോർ ദാൻ ഓക്കെ ഈ സ്ലോലി വരുന്നുണ്ട്. നെക്സ്റ്റ്
These conditions present etiology.
what is the meaning of etiology? എന്താ ഫാത്തിമ way of coming causes simple ആണ് etiology cause ആണ്. Next
Embolus.
ഇതിനാ വൈറൽ
Etiology.
അപ്പോൾ എങ്ങനെ എന്താ കാരണം CRO നമുക്ക് ആവാനുണ്ട്. ഫസ്റ്റ് കോസ് ആണ്
Embolus. 3 main types.
അപ്പോൾ എംബോളിസിന്റെ ബ്ലഡ് ക്ലോട്ട് don't say that word. എംബോലസ് ബ്ലഡ് ക്ലോട്ട് ഉണ്ടെങ്കിൽ അതെന്താണ് സെക്കൻഡ് പാർട്ട് ത്രോംബോസിസ്. ഓക്കെ എംബോലസ് ആണ് any solid object moving inside the body. The ബോഡിയുടെ ഉള്ളിൽ എങ്ങനെ കയറി അത് നമ്മൾ കാണാൻ പറ്റും. ബോഡിയുടെ ബ്ലഡ് വെസൽസിന്റെ ഉള്ളിൽ എങ്ങനെ കറക്കം മീൻസ് കറക്കമാക്കുന്ന ഒരു സാധനം അതാണ് എംബോലസ്. അപ്പോൾ എംബോലസ് മോസ്റ്റ് കോമൺലി എംബോലസ് ഏതാ മെറ്റീരിയൽ ഉണ്ടാവും? Yeah.
Include cholesterol.
കൊളസ്ട്രോളിന്റെ ഒരു പാർട്ടിക്കൽ ആയിരിക്കും.
Calcium.
ചിലപ്പോൾ കാൽഷ്യം from the bone or from body calcium is circulated.
And platelet fibrin emboli.
Platelet fibrin. Okay.
All are seen within a vessel. Cholesterol emboli.
കൊളസ്ട്രോളിന്റെ എംബോളി നമുക്ക് ബ്ലഡ് വെസലിൽ ഉണ്ടെങ്കിൽ CRAO സ്പെസിഫിക്കലി സംബന്ധമായിട്ട് ബ്ലഡ് വെസൽ ഉണ്ടെങ്കിൽ കൊളസ്ട്രോൾ ആ കൊളസ്ട്രോൾ എംബോൾസിന്റെ പേരാണ് ഹോളൻഹേർസ്റ്റ് പ്ലാക്ക്. ഓക്കെ സാധാരണ കൊളസ്ട്രോൾ എംബോളായി വെറുതെ ഇവിടെ നടക്കുന്നുണ്ട് അവിടെ പഠിച്ചിട്ട് ഹോളൻഹേർസ്റ്റ് പ്ലാക്ക് ആണ് നമ്മൾ പറയുന്നത്. പക്ഷേ CRAOന്റെ ഫോട്ടോ നമുക്ക് ചിലപ്പോൾ കാണാം, ഇവിടെ കാണാനില്ല. നെക്സ്റ്റ് ചിലപ്പോൾ ഫോട്ടോ അതിലെ ഉണ്ടെങ്കിൽ അതാണ് ഹോളൻഹേർസ്റ്റ് പ്ലാക്ക്.
Are typically refractile, orange, and seen at retinal vessel bifurcations.
So you went very fast. That means you understood what is typically refractile. Then search on Google it. You have a phone.
Shining.
Yeah. It's refractive. Okay, you are really easily able to see, and it's orange in color. And seen at the retinal vessel bifurcation. Up on മനസ്സിലാവും. Bifurcation ഇവിടെ ഉണ്ട്. ഈ ഡയഗ്രാമിൽ ബൈഫർക്കേഷൻ നടക്കുന്നുണ്ട്. വെസലിന്റെ ബൈഫർക്കേഷൻ നടക്കുന്നുണ്ട്. എവിടെയാണ്? യെസ് എന്നാണ്. The branching, the bi-branching of any vessel is called bifurcation. Do you know the Greek alphabet? Alpha, beta, gamma, phi, delta, psi. Do you know the Greek numerical? Mono, tri, tetra, penta, hexa, septa, octa, nona, deca. So mono bifurcation. Fork. There is a fork in the middle and it is becoming bi. You know fork, right? Fork is made of 4 tetrafurcation. But if you only have 2, then it is like a bifurcation. So So that's like a bifurcation happening. So wherever there is bifurcation happening, a thicker road is becoming two small lanes. What do you call lanes in Malayalam?
Layers.
Lane.
Layers.
Okay. So one big body is becoming two small body. So this big truck cannot enter the small body. It will go and stop the big place. And it will cause a blockage of the traffic in the whole place. Our traffic on a CRAO. Okay. So this is where the hardness plaque is seen. This is the vein, sorry. Now wherever there is bifurcation of the artery, so maybe here. Mostly it is near this disc only. Because if it would have been here, so it would have been heavy retinal artery occlusion. Only half of the retina would have been pale, this retina would have been okay. But if it is here, then it is central retinal artery. So hardness plaques are seen in this area normally. In this photo you cannot see. Okay. They arise from
ulcerated adenomas.
Athyroma sounds like a girl's name. Happy birthday, Athyroma. They arise from ulcerated athyromas. Athyroma is nothing but a clump of cholesterol plaques. Typically from the carotid arteries. Calcium emboli are white.
Calcium emboli are white and frequently cause distal retinal infarction.
Distal retinal infarction. So your cholesterol emboli or Hollenhurst plaques are near the disc, whereas calcium emboli that are white, not orange, they cause blockage in the distal part of retina. Distal ennaane, proximal ennaane. What do you mean by distal? What do you mean by proximal?
Distal means far.
Yeah, distal means distance, distant. Proxima is the opposite. So distal retinal circulation is blocked. Okay, girls, next.
They typically arise from cardiac. Platelet fibrin emboli are a dull white
Okay, next.
thrombosis.
So three types are there. One is a platelet fibrin emboli, one is a calcium, one is a cholesterol. There are more. I know 7 types of emboli. There is fat embolism. Sometimes some patients have fat and their fat molecules sometimes get inside the blood vessels, especially after hip surgery. Delivery, after delivery, cesarean section or some sort of a surgery, sometimes the fat gets lodged inside the body itself. So then that fat goes and just blocks the heart and the patient dies. If it's a heart attack, that emboli goes and lodges in the brain, the patient will have stroke. Most probably how Alina Moss had. It's an emboli that went and blocked a part of her brain, or probably a bigger artery or a bigger thing was blocked. This emboli is very, very dangerous. So there is a very famous comedy show called Archer. I don't know if you watch it or not. So in that, he's a very famous spy. He's a very James Bond guy. No fear, nothing like that. He's thrashing everybody. He's only afraid of 2 things, he says. One is alligators, because they are very fast. Second thing is brain aneurysms, because brain aneurysms can happen at any time and anybody can die from it. They don't even give you a warning or anything. So this emboli is almost like a brain aneurysm, but some warning is there. If a small emboli goes, so that patient will have a TIA, transient ischemic attack. TIA means if the plaque is here, this part will be paralyzed for 2 to 7 days. Then he'll be back again. Normal, so he'll be okay, fine. I have beaten it and he will start living like normal. Then he dies in 2 years. So this TIA is called as the last warning sign, because the next warning is a complete this thing. The more bigger plaque that goes in, it never recovers, that is called a stroke. Okay? Stroke is you never ever recover. What most probably happened, unfortunately, in Rina's mom's cases with that. She didn't even get a chance to have a stroke. I think she had a stroke. Then after the stroke for 2-3 days,
She fainted.
yeah. The fainting might have happened to some part of her brain, the blood did not go and she fainted. That was a stroke. That is what TIA. The TIA is always associated with CVA or history of fall in the bathroom for elderly patients. In her case, she might have fallen down because of some emboli initially coming into the brain and stopping her balancing mechanism, probably cerebellar this thing. And when she fell, she might have hit her head again, probably causing more damage to her body. But later on, that stroke never recovered and it might have lodged unluckily in a very important part of the brain. That is why she might have passed away. This emboli, these things are very serious. If they go into the eye, you're just concerned with eye because you're ophthalmologists. But since we study about the whole human body, this can actually destroy families. A small thing. So always be thankful to God and be fearful of God. Never be too arrogant. Nothing can touch me. I'm too lucky. I'm too powerful. It's a fat molecule. Okay, Anna? So. What were we studying? What was the last one?
Platelet fiber, like the you were telling
Yes.
about the other.
So there is fat emboli. Sometimes the patient are given this IV. You have ever noticed the nurse does this and that and they do tuck, 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 tuck. Why do they do that? Why? Just to look nice. You know how dangerous it is for everyone to go inside. Next time if you go to a hospital, you will be in a nightwear. With the nurse, you will probably be a nurse.
Yes.
Because I'll give you one more nightwear. The nurses don't do this properly. They get 55 injections every day. They think everybody there is spending enough time hitting them. So it's due to literally the mercy of God. But most of the times it doesn't happen. But actually in every single injection there seems to be some air or the other. So if somehow some part of the air does get into the body, it's a potential time bomb moving around. So if it goes here, it might cause some sort of paralysis of the hand. It goes to the heart attack, goes to the eye blind, goes to the blood, it's like that, goes to the kidney failure, like that. Everything is so delicate and like okay. So next time
We'll be asking. Get the airports.
that's why you need to that's why you guys need to be very actually what you can go to the best hospital, but in the best hospital one nurse can be having a bad day because she just broken up with the person. Then she did not do a proper job. Anything happens, like I'm telling you, we are walking miracles. The fact that we are all alive, especially in countries like India. Okay. Pinne, air embolism, fat embolism. So 5 I can remember. Paradoxical embolism is there. One embolism that goes to the left side of the heart to the left right side. So you get the idea, right? Embolism are dangerous, and CRAO you cannot get away without saying embolism. You have to say embolism. Main embolism is cholesterol. Because underlying 70 to 80% of patients who have CRAO, they have hypercholesterolemia. Next, please.
Thrombosis.
Blood clot. Blood clot power. In the Garna, blood clot form, other very early lecture. Some diseases there are blood clots form. More and more blood clots. Everything in a blood clots form. Okay? So that's also very dangerous. It's like a emboli machine. It is ready to make emboli every 1 second. Next.
GC.
We see the renal coverage. Next.
Other collagen vascular disease.
Next.
Hypercoagulable state.
Hypercoagulable state. Hypercoagulable state means again and again the formation of Cough spreads so fast. Cough spreads so fast. Only half an hour she has been infecting us. And I already I'm the only one without a mask. It's better to take leave in these conditions. This especially in a medical setting. Stomach infectivity, virulence, that type of mechanism of MBBS doctors, MBBS, PGs, doctors, community. They will never scold you if you have not come ready when an infected state. You can just any leave, you never get an excuse. Yes, at least there was an infected state. Okay, fine. They will always appreciate it because we see so many infections over there. So many doctors get TB. So many doctors get HIV. I don't have never seen any doctor get so far in my life. But once I was pricked with HIV pin. The patient has HIV. So actually HIV is like it's a positive or a negative state. Somebody is HIV positive, somebody is HIV negative. So you are supposed to be very careful with that. So one time what happened? There was a patient. There was a patient who was HIV positive 3 years back. And nobody touches these patients because even in the doctor's community there is so much taboo against them. That if you touch them, they might bother. Something like that. Girls, oh my god, they never ever touch the patient. Boys, until at least they try. The PGs are okay, but the juniors are not important. So I was a junior back then. I was set to prove something and I felt very bad with it. Nobody's giving him an IV, nobody's giving him medicine. So basically all the medications in medicine department are given through IV. And to get an IV it's very difficult to do. And I was very weak at it initially, so I never should do it. But later on everybody abandoned the patients. Like how Mother Teresa, she always went to the most abandoned, the unwanted, the lepers. I was not a Mother Teresa, but I'm thinking like that. So I felt like I should do something for this guy. So I went and he's like thin, extremely thin. If you take his skin, it's like paper. And the veins are even thinner, like an arterial narration, it's like a venular narration. So it's very difficult to find an IV. Somehow I found an IV. So I used to double glove, triple glove, double mask. I think, why? It doesn't spread by touching, right? Why am I doing so much?
But any infections is
Okay. So the cough has some saliva, which can actually go. But HIV doesn't spread to saliva. Because the disease spreads through this coughing things, droplets in the air, and everybody's inhaling perfume. But in the case of HIV, blood is the main, most dangerous, virulent, media through it. So you're actually literally dealing with blood. So it's blood, this thing, a small prick, micro prick happens in my skin. Blood goes in that center, I'm done for life. That is why people don't bother with that. But I knew it's a Z positive. They call them Z positive. They don't call them HIV positive. Because it's a very taboo thing. So they call them Z positive. So in the file it's written red color, Z positive. Nobody touches it. I went there, triple gloving, and I finally got it. Alhamdulillah, his life was saved then. He didn't die that night. Maybe he might die 6 months later on a very sad case. So once one of these cases, one day I got pricked. I pricked that guy and he pricked me as well. So immediately the protocol is for pricking, just for pricking. The blood did not enter there, blood did not enter. The chances of me getting HIV is 0.001% through pin prick. So there was this scam, this scare going on in USA where people were not treating these HIV patients in the 1970s and 1980s. It was an early thing for them. Every doctor was afraid they might come to me, they did not bother touches. Even doctors were very unaware of that time. So they were not treating them. So these people, the moment they got to know that they are HIV positive, they should take the needle, prick them, and then take the try to prick them out of sheer vengeance, or to show them that if you don't treat me, I'll prick your right. So they should terrorize them. Because they were also fed up of life. Because everywhere they were being subjugated. So the one place who should not subjugate them, I mean, that day, if he does it, So I have an uncle who this happened to him. They didn't prick him, but they terrified him. So this was a thing going on in the USA where these people they were about to die in 6 years, 5 years, 3 years. Till now, full-blown AIDS not happened to them, but in a initial period of AIDS, they were able to go out and mingle with the normal people. People don't know they're having AIDS. So there were some pricks or pins that were left in the theatre seats. They were putting the pins in the theatre seats and waiting. It's like medical terrorism. I don't know why they were doing it, but it was a huge scandal. Imagine one news like this gets out. Will you ever sit in a sit normally without breathing? And that time in a year, 30 to 40 cases were happening. Because the AIDS people did not know what to do. They wanted to get back
So
at
they
the world.
also started
They were
Theatre,
yeah. So they were trying to get back at the world. So this thing started back in the USA. So this pin prick is a big deal with HIV people. That happened to me. Then I went and I took Zidovudine, some viral cocktail is there. So to take that, within half an hour it just knocked out. So powerful. You can't stand and work out there. I wanted to work. I've had HIV, I've had this hepatitis patients, everything I've dealt with. Never anything bad happened to me because of HIV vaccine also. But this, when I took a cocktail, I just like started getting faint and I could not work anymore. So normally what happens, the mentality in the internship is for medical people, not for you guys. You can die before you can take a leave. Our mentality, no. Special doctor in the field. That's why these PGs are so relaxed because we have finally come across that internship, not that part. So MBBS is hell, but this is like the last stage of hell, internship. After that, PG life is slightly chilled out. Then consultant life is even more chilled out. It gets better and better in doctor's life. So that was the hell life at that time. That was the first time I had asked for a leave, and everybody understood. Okay, fine. This was one time where we can leave. So let's see. So in the field of medical community, if at all somebody does not come to work and tells them, sir, I cannot come to work because instead of one doctor being infected, I could have infected 6 doctors. And then you all would have gone to your houses and then you all would have had a small flu epidemic. They always say, okay, fine. Okay. First of all, don't get infected, but if you do get infected, have the courtesy of staying back. They don't never scold us. That is the only time they never scold you for taking a leave. Because we know how dangerous it is for the person. So, yes. Where did you reach? Hypercoagulable state. So, hypercoagulable state is basically that state, like that machine, which is making emboli upon emboli upon emboli upon emboli, thrombosis upon thrombosis upon thrombosis. It is always circulating the thrombi, and it is basically causing so many. So, what are the diseases in which the machines can be made like that?
So it is a repeated formation
of blood clots. Okay. One is polycythemia, another is multiple myeloma, another is CRAO. And why multiple myeloma will have this is probably beyond your paycheck. So I won't disturb you with that. Polycythemia also I know how they are working, but you guys just need to listen to it once. I don't even think for your level, if you say hypercoagulable states or blood dyscrasias, it's more than enough. You don't need to mention any of them. Blood dyscrasias. Just say hypercoagulable states. Use the easy words. So, microglobulinemia, antiphospholipid syndrome, factor V Leiden, activated protein C resistance, hyperhomocystinemia, protein C NH deficiency, antithrombin 3, mutation, prothrombin mutation G20210A, etc. I know everything about everything. If you ask me any disease, I can tell you 5 minutes why this disease is causing, but it's not needed for you. It really gives you a respect for doctors. Sometimes I forget like how great we are. Because I feel like, yeah, we know every doctor and every doctor knows this. And when you realize that, like how easy your life is. Considering you don't have to know all these stupid things. But I know every single formation of factor of vitamins. That is what it takes to be a doctor. And it's only till the MBBS level. For you to become an ophthalmologist or orthopedic, that's another level. So I on the one hand, I do say that their life gets chiller and chiller as they go further, but they have spent so much time also to get to that. So much expertise also they have here. Not just like they were sitting on hand and beating mosquitoes at the mission level. It's very difficult to get. So next,
Rare causes.
their causes of CRAO,
Migraine.
migraine.
Acid disease.
Let's not discuss rare disease. Next,
Syphilis.
next. Let's not
Trauma.
discuss it. Trauma. How will trauma causes? No need. This is all useless etiology. But the most important etiology you should say is emboli and
In hypothalamic state.
yeah, these three is enough. Next, how will we start to treat the patient when he is inside the OP? Fatima? Yeah, welcome.
Immediate ESR.
Immediate.
ESR.
Why is yeah. Immediate ESR. This is the first time I'm hearing this point. Should do an immediate ESR, CRP, platelets to rule out GCA if the patient is above 55 years of age. Okay? 55 because GCA happens above 55 years of age. So there is one thing. There are two things. One thing is CRAO. Is CRAO reversible, Dina? Is the vision loss reversible? Will the patient get his beautiful vision back? Never. Otherwise, this will not have been such a big topic. Since it is irreversible, we are studying it in such detail. How many eyes are affected in CRAO? One. Unilateral. Okay? There is a condition which starts as unilateral but can affect both the eyes 100% if you don't treat it properly. That condition is called GCA. Giant cell arteritis. In giant cell arteritis, what happens? It starts as a uniocular loss of vision, but then it 100% spreads to the other eye also. So your job is to find out whether this is a CRAO only to the CRAO or does it also have an underlying GCA as the cause. So if that thing is there, then if the patient age is more than 55, then the most important test to be done is ESR. So if ESR is high, then it is GCA. So you have a CRAO guy who's 55 years of age and you did an ESR here, and ESR is high. So you are no longer just worried about one eye that is completely gone, you are also worried about the good eye also. The next eye also will also get gone. No longer you can do anything for the affected eye, but the other eye you are trying to save now. But in CRAO you don't have to worry about the other eye. Because it's a matter of luck that this eye is gone. Spread it won't spread to the other eye. One second. Then you're supposed to start systemic steroids. That's the main thing. High dose steroids for GCA. Yes, continue this.
Second one, check the blood pressure.
We're checking blood pressure because it's generally that high BP is associated with CRAO. Generally. Okay? High cholesterol and high BP are both associated with CRAO. Next.
Other blood tests. Fasting blood sugar. Glycosylation.
HbA1c. Yeah. Next.
Complete blood CBC with differential prothrombin time activated partial thromboplastin time.
So you're trying to find out the prothrombin time, activated partial thromboplastin time, to find out whether the patient is having any hypercoagulable states or not. Is this clotting normal or not? Okay. I don't know why we are trying to find out diabetes and why we are trying to find out CBC makes sense because if there is more platelets in the CBC, then there is a hypercoagulable state. Prothrombin time, activated partial thromboplastin time will also be for find the hypercoagulable state. In patients younger than 50 or with appropriate risk factors or positive review of systems, consider lipid profile. Okay, now more than 50 cholesterol, more than 50 BP, more than 50 GCA, more than 50 diabetes. Yes? What if a 25-year-old young healthy guy with no cholesterol, no BP, no diabetes is coming to you with CRA.
Trauma.
Post-trauma, let's put commercial retina in there. It's very rare that trauma can cause CRA. If you have CRA like things post-trauma, cover it commercial retina. Make life simple for you guys. Okay, fine. There is no trauma. Strange, fascinating. What the hell is happening in this body? No BP, no cholesterol, so there cannot be any emboli. No hypercoagulability, so there cannot be any blood clots. No diabetes, I don't know why that is important. But also no trauma. All the causes that are normally associated with the CRA are not there. So this guy is something special happening. He is having, if it's a young patient less than 50 years of age, then you have to think of some other risk factors. Like, you should still think about lipid profile. Some people have something called as fatty liver. Young people can have fatty liver. They drink so much that they eventually, their liver becomes useless and it becomes very fatty. And that fatty liver can also cause this thing, emboli. Anti-nuclear antibody. Anti-nuclear antibody is something called as SLE, systemic lupus erythematosus. You don't need to know that much, but SLE is very famous. I think lupus, have you ever seen this English show called House MD? There's a very famous show called House MD, in which he's a doctor and he's like talking about diseases and this and that and all this. So whenever anybody is not able to diagnose anything, he will just say maybe lupus. Because lupus is always the last diagnosis to happen. Just like how we have not able to diagnose anything, it could be lupus. So lupus means they will have ANA, anti-nuclear antibody in their body. Rheumatoid factor, that means they have arthritis. Sometimes arthritis can also cause this. Fluorescent treponema antibody FTAABS is a test that is done to find out whether he is having syphilis. Syphilis can also cause CRA. Serum protein electrophoresis, hemoglobin electrophoresis to find out the platelet count and other things. And further evaluation for hypercoagulable states. So in these people, what are the causes if it is less than 50 years of age? You have to think of lipid profile. You have to think of SLE and anti-nuclear antibody. You have to think about arthritis and rheumatoid factor. You have to think about syphilis and FTAABS. You have to think of other hypercoagulable states that can happen in young people. Okay? Also, it can help in doing carotid artery evaluation by duplex. Have you ever seen this Doppler? Any of our family members have ever had? Every family member in every house has had this. Probably you guys have never paid attention to. Maybe you did not have enough knowledge. It is called as cardiac echo. Echocardiogram. Duplex. Doppler. Angiogram, all these things are duplex Doppler scans. That what you do is you try to find out the carotid artery and find out the flow of blood in this body.
Cardiac evaluation with electrocardiography.
You do an ECG also, right? Makes sense? Yeah. ECG ने എവിടെയാണ് ആവശ്യം നമുക്ക് സംബന്ധമാണ് കണ്ണിന്റെ ഡിപ്പാർട്ട്മെന്റ് ECGന്റെ ഇവിടെ എന്താണ് കാര്യം elaborate so basically emboli what it can do to the eye is dangerous but what it can do to the heart is off the charts. So if you're a guy, an intelligent guy who's saying there is emboli, the value of emboli is happening inside the body, why don't you try to look at the heart also? Is the heart safe from me? You don't do it, you also put you send it to the doctor saying he has a CRAO. So whenever CRAO is there, medicine people will say, oh, check for his emboli. Is there emboli anywhere else? Is it emboli about to go to the brain? Is there emboli about to go to the heart? And they do cardiac echography, Doppler, this scan, Doppler and find out the Consider intravitreal intravenous fluorescing angiography, FFA, electroretinography, both confirmed with FRCS. Hello. Thank you. Okay. Location Al Salama Eye Hospital. Al Salama Eye Hospital. Al Salama Eye Hospital.
Okay, sir. Okay, thank you so much.
Thank you. ചില ഡോക്ടേഴ്സിന്റെ സ്നേഹമുണ്ടോ ഇവിടെ? Okay. Yes. Consider highly fluorescent angiography, ERG, or both to confirm the diagnosis. Yeah, you do a IV fluorescent angiography. You put a dye in the patient's body. The dye goes in the brain, but it gets blocked at the retina. There is no dye going inside. It's completely dark. That is, you know that there is block of the central retinal artery. Dye is entering the veins very nicely, but it is not entering the arteries. Please continue.
It has been suggested that only patients with high risk characteristics of cardioembolic disease merit echocardiography,
Yeah.
including a history of subacute bacterial endocarditis.
Next one, please.
That's right.
Yeah. And again, read the treatment.
Treatment. There are anecdotal reports of
What does it mean? Anecdotal. We read so fast in that. What മനസ്സിലായി? Huh? No. Jinna. Anecdotal reports in your somewhere here or there. Not reliable is correct. Somewhere. What did you say?
Not proven.
Proven is correct, but it's not the correct. Anecdotes is data that has been gathered from a single guy listening to somebody else. For example, if I say, I have never seen anybody have PL minus in CRAO. Mostly they are CF. Can you base a study on that? Can you write in Google that CRAO will never have PL? Can you write it? Can you write a research like that? No. Why?
Because
Only I have told. And where have I got this report from? By looking at my patients. It's an anecdotal evidence that I'm giving. Anecdotal evidence is that I have never felt. But anecdotal evidence is important. So you might suggest that anecdotally speaking, Dr. Nawaz has never seen any case like PL minus. This PL minus is very odd for the CRA. So you will be guided by that, but it's not a double-blinded, controlled study. Okay? And double-blinded controlled studies are the most perfect studies. Means there is no anecdotes important. There are 3,000 people coming the sample size, giving theses, null hypothesis, all those things. So there is not a thesis or study that has been conducted. But anecdotally speaking, most of the doctors tell that it is how this is. If they are conducting a proper study, they have told that is what their experience tells them. So in somebody's experience, listening from somebody single is called as an anecdote. Or an anecdote is basically listening to somebody's story. For example, what I just told you guys about this HIV is an anecdote. Or the case about Satish sir doing that particular is an anecdote. All these things that I told you, so you have an anecdote now. So you know that sometimes autoclave will have some bacteria. Sometimes HIV patients, the pinprick. So for example, anecdotally I have heard that HIV spreads through pinpricks. But the research has told me that it is 0.0001%. Never have I seen it happen. Okay? Again, anecdotal. So there are anecdotal reports of improvement after the following treatments. if instituted after the 90 to 120 minutes of the occlusive event. That means the treatment for CRAO is useless. That means there is no treatment for CRAO. If you have to think about some treatment, you have to go by anecdotes that people gave you. Dr. Ravindra Krishnan, he did this, and he said there is some advantage. Dr. Mohammed Sir did this, and he said there is some advantage. Dr. Gordon Ramsay did this, and he got some advantage. അങ്ങനെ നമ്മളൊരു anecdotal evidence ചെയ്യാൻ പറ്റും, പക്ഷേ റിസർച്ചിന്റെ പ്രകാരം അങ്ങനെ ഒന്നും ട്രീറ്റ്മെന്റ് കറക്റ്റ് ആയിട്ട് പ്രൂവ് ചെയ്തവരെ ആയില്ല. ഓക്കെ, അതെന്താണ് anecdotal ട്രീറ്റ്മെന്റ് എന്താണ്? അത് റോബോട്ട്.
None of these treatments have been proven effective and randomized.
You have to read the first from the first one.
There are anecdotal reports of improvement after the following treatments if instituted within 90 to 120 minutes of the occlusive event.
That's the important thing. You remember at the start of the class I told the good thing about CRO is the patient comes to you running. Like how in fungal ulcers, they are a little bit lazy, chilled out. They come to you after dancing every day. But in the case of CRO, they never take vision loss, sudden vision loss is likely, and they come to you running. So you have a good advantage of catching the patient in the most sensitive time. What is the most sensitive time?
90 to 120.
Yeah.
None of these treatments have been proven effective in randomized, controlled clinical trials.
Okay. Answer. None of these treatments have been proven in randomized, controlled, double-blinded clinical trials with no bias. That's the most perfect study. അങ്ങനെ സ്റ്റഡി ചെയ്യുമ്പോൾ നമുക്ക് ഇതിങ്ങനെ ഒന്നും പ്രൂഫ് കിട്ടില്ല. പക്ഷേ ദിന ഒരു സ്ഥലത്തിൽ വർക്ക് ചെയ്തിട്ടുണ്ട്. അവരോ ഡോക്ടറിന് ചെയ്യുമ്പോൾ സാർ പെട്ടെന്ന് നമുക്ക് ലാഭം കിട്ടും. ഓക്കെ ഞാൻ ചെയ്യാം. അല്ലെങ്കിൽ ജർമ്മനിയിൽ പോയിട്ട് 2 വർഷം ഒരു ഡോക്ടറിൻ്റെ താഴെ വർക്ക് ചെയ്ത് അവിടെ നമ്മൾ ഇത് ചെയ്തു. ഓക്കെ ശരി ചെയ്യാം. Similarly, that sort of anecdotal evidence is only helping us. ഇതുവരെ ഇത് പ്രൂവ് ആയില്ല. ഏതോ ചുമ്മാ നിങ്ങൾ ചെയ്തിട്ട് നമ്മൾ ട്രൈ ചെയ്തിട്ട് ദാറ്റ്സ് ഹൗ ഇറിവേഴ്സിബിൾ ഇറ്റ് ഇസ്. ഒന്നുകൂടി CRA ആവുമ്പോൾ പിന്നെ ഒന്നും ചെയ്യാൻ പറ്റില്ല. Still, let's see what they are trying to do.
Immediate ocular massage with fundus contact lenses or digital massage.
വളരെ ഫാസ്റ്റ് പോകുന്നുണ്ടല്ലേ അല്ലേ?
Immediate ocular massage with
മനസ്സിലാവും.
fundus contact lenses.
മനസ്സിലാവും. ഇമ്മീഡിയറ്റ് ഓക്കുലർ മസാജ് മനസ്സിലാവും. പിന്നെ ഇമ്മീഡിയറ്റ് ഓക്കുലർ മസാജ് ഇങ്ങനെ ചെയ്തിട്ട് okay, you are trying to just somehow lose the Harden's plaque in there. Somehow you are trying to put some pressure.
With fundus contact lenses.
Fundus contact lenses, 90-day or gonioscopy. Or there is a special contact lens called fundus contact lens, which is for this purpose. You just put it on the eye here with the pressure. Just check what is fundus contact lens. Check on Google. Yes. Yeah. So fundus contact lens is that lens that you use while doing laser.
Yeah.
Okay. So you do that while doing laser. So you put that
Yeah, gel.
coupling medium.
Yeah,
You open the lids and you put it in the eye. So that is like a good contact is happening on the eyeball. Then you start pressing on this slowly, not like how I'm doing. Then you try to dislodge the Harden's plaque. What else?
Or digital massage.
Digital massage. What is digital? Zoom, through Zoom call. Why it is called digital? Very better now. You know, nice cooling your hair. This is called digits. Okay. These boys and girls ask each other for digits in there. Give me your digits, give me your digits. You know what it is? Number for your digits. But I think in starting. Why are fingers called as numbers? Because back in the olden days we used to count numbers on our digits. 1, 2, 9885. They give the number later. Okay? So that is where the numbers came from digits. But digits actually means this thing. So digital fingerprinting they call it, right? What does that mean? It's fingerprinting of the fingers. So why is this technology called digital? Exactly. It's like on the world on your fingertips. That concept is there. So everything is digital. Second thing is it's all based on ones and zeros. Another digital. Yes, you're with me? Infra within the layer one. Right? So now digital massage also you can do.
Anterior chamber paracentesis.
Why? എന്താണ് anti-chamber paracentesis? Anti-chamber injection you take the fluid out. Sometimes you can reduce the pressure. Next.
IOP reduction with acetylsphonamide 500 mg or 250 mg tablets, PO, or a topical beta blocker, Stivalol,
Levodopa. Okay, basically try to reduce IOP. That is also having the same effect, like how you are trying to put the aquasteamer out, changing the pressure, you are changing the pressure over there and expecting something might happen to the patient's dislodging of the hardness flash. Something you are trying to do that you can lose and come out. Suddenly the blood will come out, come in again and everything will become fine. Then
hyperventilation into a paper bag to induce a respiratory acidosis.
very fast you are going, understanding every word.
Hyperventilation into a paper bag.
That's fine. Try. You went very fast. You have to tell me the meaning. Hyper means
Let the body eliminates more carbon.
why you want all this? Ellen always gives the most complicated answer.
Rapid breathing. Rapid breathing.
Very simple. Hyper, more. Ventilation, in and out. So, hyperventilation. Have you ever seen who has traveled in a plane here? They don't do it these days. So you never travel? Yes. Sometimes in plane, you have nausea due to the temperature, the altitude change, and they get nausea. Or sometimes maybe the plane is moving like this, they got nausea. You know what they do? It's so comical. They give them a paper bag, and they ask to put the paper bag is.
I've seen that.
In Hollywood movies, it sounds right? We've never seen any. Have you ever seen
I
that?
have seen, like, we used to have that nausea, that bag in front of us, right? For the Orbital. This guy, he started taking it, was just breathing.
Yeah. So I used to think that is why I used to think I think it's for to get the vomit inside. Disgusting. But when I was a child, I used to think that. Now that I know that there is some mechanism which, if you keep on breathing bad air, it's like good air. If you keep your paper bag over there, you're just putting on bad air and again taking the bad air. Hello. Nice one. Open button. Class. I think 11th level. मुझे तो याद है कि उससे भी कम था वॉचिंग वो जो गोरे अंकल थे मुझे पता नहीं वो कौन सा में है, बट हम जिसके घर पे गए थे ना एक बार, जहाँ की लड़की तेरे पास हमेशा आती रहती थी, उससे बात करने के लिए नेट लगा था। हाँ वो शायद 11 या 12 हो सकता है, मेरा 12 की तरफ ज़्यादा जा रहा है। अल्लाह हाफ़िज़। So something happens, it seems, when you're taking bad air, breathing in, and again taking bad air, breathing out, again taking bad air. Bad air basically means air that has carbon dioxide rather than oxygen. So it's bad for you, right? So when the air starts to go inside the hypercapnic air, or the air that has carbon dioxide, it changes some mechanism in the brain, and you suddenly stop feeling nauseated. Maybe the body is thinking that you're about to die, and it gets into fight or flight hormone because you're getting less oxygen problem, and then it distracts your body from nausea feeling, because nausea and digestion and delivery, these are things that can only happen when the body is completely relaxed. You know, these women in the olden days when they used to get a tiger, they used to stop their delivery, their body used to, normally when they're going to labor, after 1 to 5 hours of labor, then the delivery happens. Right? So at that time, if danger comes upon them, suddenly the body's labor mechanism stops, so that the girl can run. Body gets more strong, and the more blood starts circulating. It's the body very fascinating. So you can trick the body into thinking we are about to die. So the body's nausea mechanism, vomiting mechanism, those mechanism are things of relaxation. When you have a lot of time to relax, to vomit. If you're in a fight and you're vomiting, then it's not good for you, right? So the vomiting, everything stops. I think that is the mechanism behind this paper bag thing. In this condition, here also you are trying to do the same thing, but you are trying to increase the carbon dioxide in the body more by taking in carbon dioxide again and throwing carbon dioxide against the income. So your body's oxygen levels are reducing and carbon dioxide is increasing. So carbon dioxide has a habit of making the blood vessels bigger. Why? The more arteries are becoming big, the more blood can be pumped through. And when you have less oxygen in the body, you want more blood to be pumped everywhere. So the body is thinking, oh my god, this guy is not getting enough oxygen. And he's dilating on the blood vessels. So you are tricking the body into opening the blood vessels, and that's dislodging them. That's a complicated point. Huh?
So the carbon dioxide comes to.
Yes, vasodilate. Okay? Because the body is thinking there is less oxygen, let me open all my blood vessels completely. And when I open the blood vessels, the thing is getting dislodged. That is the wisdom behind it. Whose voice is this? What's she saying? She's speaking to opticals. She speaks to customers like that?
She's on the phone, I guess.
Oh. On the phone, every Malayalam is like that. That's my experience. Before I learned Malayalam, I used to feel like not able to distinguish whether somebody is rude to the phone or somebody is in a fighting, especially when I didn't see their faces. But then I said, Malayalam never fight, everybody is always happy. It sounds like, the cadets looks like they're about to fight. There's one person who I always felt she's fighting, about to fight, or maybe she's fighting somebody. I heard of so that is it. My God, she used to shout like the roof used to blow from the room. Now she's a lot more calm. But maybe initially she wanted to become the branch manager. I think she thought she was going to shout her way to the top. If she becomes the loudest in the room, she'll become the most important. I used to get so annoyed with her. All other doctors stood sitting, the junior doctors, and she'd keep on shouting front of them. Some sort of a body language power move to show that I'm not scared of anything. Stupid things people do. The treatment is finished. This stupid useless treatment. It is completely. You have to think about it like this. If you think the treatment is useless, then you know how much the disease is dangerous. We are trying everything, we are throwing everything in the kitchen sink at it and assuming it might work, but it's not going to work. Nothing ever works like that. Okay. Follow up.
Follow. Refer to an internist for a complete workup as above.
Very fast way. First level. Huh? International level. Internal medicine
Medical
specialist.
specialist.
Internal medicine specialist. He deals with heart, he deals with lungs, everything. Send the patient to him. Then he will decide where to send the patient to next. Because his heart is anything to do with embolus. He's very afraid of the brain and the heart. Instead of sending him to neurologist or to the heart guy, send him to internal medicine specialist and he will take him to cardiologist and he will send him to neurologist.
Repeat examination in 1 to 4 weeks.
Repeat examination 1 to 4 weeks. Call the patient after 1 month. Why? Because it is self-resolving. The vision will be back. Vision still get to. Then why are you calling?
It's irreversible.
It's irreversible. Then why are you calling 1 month later? Just to cause trouble in his life, to humiliate him more. It's very important. What is important?
Checking for neovascularization of the iris, disc, ankle,
Second irritation. Already retinal പോയി കാഴ്ച ഫുള്ളായിട്ട് പോയിട്ട് അതിൻ്റെ മേലെ അവിടെ ഫുൾ തീരെ ഓക്സിജൻ ഇല്ലല്ലേ അപ്പോൾ ബോഡി പുതിയ ബ്ലഡ് വെസൽസ് തയ്യാറാക്കാൻ വേണ്ടി ട്രൈ ചെയ്യാം ആ സമയത്ത് വെജഫ് blood vessel because the body is trying to somehow desperately getting oxygen. Body is thinking, oh my god, the oxygen is stopped to the retina. He is already blind or not, he doesn't care. Get some blood vessels. Blood vessels, come. And then a signal to pay VEGF. So VEGF. Because neovascularization, ഇത് വളരെ dangerous process. ഇത് കേട്ടുമ്പോൾ എത്ര നല്ല പ്രോസസ് ആയിട്ട് കണ്ടിട്ടില്ല so body is trying to help so nicely. Body in a short term anybody who tries to help, if you have a husband who is trying to make a life with you, slowly building a house with you, getting a small car then a big car, that is always better than the rich boyfriend who suddenly gets you a car, suddenly gets you this. It might seem like okay he's doing a lot, but then it's temporary. He's also suddenly. Yes, it's like our bodies, things are like that. Even though there might be ups and downs in the body's mechanisms, but slowly things last much longer. Suddenly the things that the body tries to do, they never last properly. They have a very temporary effect and they are actually much more dangerous. Now why is it dangerous? Why is new vessels on the retina dangerous?
It might be
It might?
bleed.
Very good point. Because it has been made newly. Okay, it's not a relationship that is made with a lot of years. Within 2 days, this relationship starts. So a lot of holes are there. It's very dangerous. Huh?
Relatable.
Relatable. Hashtag it. Yes, that is the point. It can bleed. Second.
No
Second
oxygen
item.
supply.
No? Second I'll tell you. Retina നമുക്ക് എങ്ങനെയുണ്ട്? Yes, about. സാധാരണ retinal vessels എങ്ങനെ ഉണ്ടാവും? On the thin layer. A thin retinal arteries ഇങ്ങനെ just a surface മേലെ പോകും. അല്ലേ? അതിന് വല്ല ചെറിയ വളരെ paper thin layer ആണ് intermediate membrane. So intermediate membrane under that thin retina only in the surface. Yes. Does any artery ever try to come across the retina, beyond the retina, and enter the vitreous? Does vitreous have arteries? Confused on that. Does vitreous have arteries? Does aqueous have arteries? Does cornea have arteries? Does lens have arteries? Why? Because we want them to be transparent at any cost. Blood vessels are extraordinarily important. God has still not put them there. Because transparency in that case is more important than blood vessels. They will somehow adjust with oxygen. Allah Ta'ala has made aqueous to give oxygen to the cornea. Tear film to give oxygen to the cornea from the stomach. There are so many mechanisms with which lens is getting oxygen, all these things without blood vessels. But transparency is that important. That is why there is no blood vessels in all the media, from cornea to aqueous to lens to vitreous. Vitreous can never have blood vessels. If vitreous somehow has blood vessels, it's called as hyaloid remnants, or it is called persistent hypoplastic PHPV, interest membrane something like this. If it is behind the lens, it is called Mittendorf's dot. If it's near the disc, it is called Burger's hyalodicapsular ligament. No, Mittendorf's dot. What is it called near the? How do you forget this? It is called. The remnant of the artery near the optic disc is called what? One is from the optic disc, it goes to the disc, so the lens, the old artery. When we were putties in our mom's wombs, and when we go out, that artery is immediately destroyed. Chelal karki, cherry piece baaki. Yes. I have thought, how did I forget? Find out. Remnant of the thyroid artery near optic disc. Mittendorf's dot is on the lens. Burger's ligament arm. That is on the lens. Burgmeister's papilla. I'm saying Burger's ligament. Burgmeister's papilla. Sometimes the disc is there. Burgmeister's papilla. You never heard of it? I taught you 5 times.
Yes.
You cannot say this. The disc is there. Sometimes the disc is having some nice curtain, some nice clothes it is hanging on the disc. That is Burgmeister's papilla. Because that is where the artery was first there. Then it got destroyed, but that part did not get destroyed. So if it is on the lens, then it's called Mittendorf's dot. If it is on the disc, it is called Burgmeister's papilla. So arteries can never be friends with vitreous. Just like so many people in life who are not meant to be friends, vitreous and arteries can never be friends. Okay? Vitreous media should be 100% transparent. Now imagine these new vessels who are in a temporary relationship with lots of holes are now also trying to invade the privacy of the vitreous, growing inside the vitreous. One day you look like this, the vitreous is moving and it will take the blood vessels and it has a retina. Because in the vitreous media, the blood vessels are going like this and attaching nicely. Like they're having like roots in a tree. And when you suddenly move your eye like this, or there's something like this, or the vitreous is getting loose because of age, one fine day the attached arteries will just pull a thin laser, paper thin retina of the RPE, and that is called as retinal detachment. It is specifically called as tractional retinal detachment. Most commonly seen in TRD. Most commonly seen TRD is equal to this. This is equal to TRD. Proliferative diabetic retinopathy. PDR. PDR start ആയാലേ നമുക്ക് എന്താണ് വരും TRD. Oh my god, this is going to TRD. They are constantly worried about the blood vessels going to the vitreous and is pulling the retina. Till now, the retina and the vitreous had no connections. Yesterday, where they were beautiful at she was in that building, this guy was in this building. I'm going to have a relationship with that. But now they're putting the ropes. There's so many things. They're pulling from person. That's very dangerous. This retinal detachment can happen. The vitreous can go and cause issues. Okay? So we are afraid of TRD. Now, that is why it is not enough that this guy is going through loss of vision. Now within 1 month, one extra headache will start for him, which is neovascular. But till now, I was only talking about neovascularization of the retina. Imagine whenever this VEGF is calling VEGF, it's not only going to the illness ears, it is also going to the optical ears. I only want vessels to come from her and from Anil and from Fatima. But sometimes my VEGF signal is being heard by that Indian guy sitting in the fashion. So suddenly he's also having some neovascularization. So it's a very capricious, a very unbridled, very uncontrolled way of growing vessels. These kind of relationships that never last long. No? You know where else the vessels start growing from? What is retinal? That everybody knows. That is called neovascularization of retina, or NVD or NVE. There is another thing called NVA. NVA. NVA is neovascularization of the angle. This VEGF is reaching, spreading to the front of the eye, and that delicate part where there should be no vessels and nothing, the media should be very clean. There also the blood vessels are coming. So it is called as neovascularization of the angle. So that is why that is written there. NVI. New vessels on the iris. Should there be new vessels on the iris? Or should there be any vessels on the iris? Never. Should there be any vessels on the disc? Extra vessels, new vessels. No. Should there be any new vessels in the angle? No. Should there be new vessels on the retina elsewhere? No. Okay? So NVI, D, A, E. We are all afraid of these four things. 1 month later. How fast can they come? These new vessels.
4 weeks.
Within 1 week, sometimes. Very rare. That is how fast they come. So 1 month, 100% you should call the patient back to look for new vessels. Which develops in about 20% of patients at 4 weeks after onset. If new vascularization develops, what do we do?
Yeah.
If you say laser, I will ask you focal laser, macular laser, grid laser, DRP, or PRP. I will ask you this 5. Your answer should always be PRP. There is only one thing you can do for laser, for new vessels, and new vessels only one thing you can do, that is PRP. PRP means new vessels means PRP. There is no other thing done for this. Because this TRP, YAG, these are all other things are done for some macular ischemia, all these things. But the moment you see a new vessel, whole of retina is destroyed. That is how much you are afraid of new vessels. You are willing to kill the retina with guns, with crazy machines. That is how much you should run away from new vessels. New vessel is a dangerous entity. One new vessel is Kanamadi. They start just destroying the whole retina. If the whole retina is destroyed, the patient blind now.
Before.
They never destroy the forehead. That is why you should know the forehead importance. Now I'll ask you a very nice question. Your brain will start thinking like Sherlock Holmes. You become like Sir Arthur Conan Doyle. Imagine the unlucky scenario where somebody is having a new vessel on the fovea. You will destroy the fovea. And you cannot let the new vessel grow and grow and grow and grow and wait for it imminent retinal detachment. What injection? Paracetamol?
No. I
Anti-VEGF. ഇപ്പോൾ മനസ്സിലായോ?
Yes, so it's like so easily.
Anti-VEGF. Register injection. ഇതാണ് injection. പേഷ്യന്റിന്റെ മാക്യുലറിന്റെ മേലെ ഫോവിയയുടെ മേലെ എഡിമ വന്നിട്ടുണ്ട്. അവിടെ എഡിമ വന്നിട്ട് അവിടെ ഫ്യൂച്ചറിൽ ഇസ്കീമ ആയിട്ട് നമുക്ക് ന്യൂ വെസൽസ് തരാൻ ചാൻസ് ഉണ്ട്. സോ ഫോബിയ എൻവോൾവ്മെന്റ് ഉണ്ടെങ്കിൽ നമ്മൾ ഇഞ്ചക്ഷൻ തരാം, ഫോബിയ സെറ്റിൽ ആവും. ബാക്കി എല്ലാ സ്ഥലത്തും നമ്മൾ ഗൺസ് ചെയ്തിട്ട് ഡിസ്ട്രോയ് ചെയ്യാം. That is where anti-VEGF injections are a game changer in medicine. Retina in the field, anti-VEGFs are like this golden ticket. ഇതിന് മുമ്പ് നമുക്ക് മാക്യുലർ എഡിമ അവിടെ എന്താ ചെയ്യാം? We used to give this നെപ്പഫെനാക്. അതല്ലേ നെപ്പഫെനാക്, അത് കാണിച്ചാൽ മതി. നെപ്പഫെനാക് ഇംഗ്ലീഷ് ചെയ്തിട്ടുണ്ട്. This was our best friend before laser, before anti-VEGF injection. Okay, anti-VEGF injection started in 2003-2004, very recently. അത് കഴിഞ്ഞിട്ട് റെറ്റിന മൊത്തം ചെയ്ത് മെഡിക്കേറ്റഡ് നമുക്ക് എല്ലാ കാര്യങ്ങളും സോൾവബിൾ ആണ്. ആദ്യം ഇൻവെസ്റ്റിഗേറ്റ്സ് നെപ്പഫെനാക് ആൻറ്റി anesthetics. It's little like paracetamol. I was teasing her, right? What injection give paracetamol? This is literally paracetamol. Second NSAID. I gave NSAID and we just expect maybe inflammation to go. So now we know that we have anti-VEGF. So when we give anti-VEGF, you're not only saving the retinal phobia and everything, you're saving the whole of the eye. Everywhere anti-VEGF is going and just telling, don't come VEGF, don't come VEGF. Okay? So nowhere VEGF is coming. That is your basic mechanism behind an anti-VEGF injection. Now, how much anti-VEGF is supposed to be given? What is the name of the anti-VEGF? Bevacizumab, ranibizumab, aflibercept, Avastin. These are all different, strictly different. Diabetic retinopathy particles of the part. But CRAO, it's very simple at a CRAO and it's just stories on the world. Okay? This aspect is CRAO. I never thought about CRAO in this aspect.
It's like a story. Yeah.
This should always really push your brain. The people who are writing this are like people who have written Sherlock Holmes. Our mindset in the if we don't behave like Sherlock Holmes, then we are the idiots. New escalation hour 2 weeks ago, we can use your brain. Oh, full oxygen going. Then new escalation hour. Our image VEGF angle iris chance, the disc chance, that's how you should be thinking. Okay? If you think in those terms, you never have to really revise it in that manner. Just think the sequence. Okay, treatment, symptoms, initial treatment, treatment is with us, try for follow-up like that. Okay? Up to 20% of patients at a mean of 4 weeks after onset. If neovascularization develops, perform PRP and or administer an anti-VEGF. Okay? Fine. Dena is always on power saving model. Nicely energy conservation. She was thinking very highly but keeping very low. Amana is always on performance mode. Okay. Now power saving mode, Dina. You were very quiet the whole class. Now, please tell me symptoms for CR.
Painless loss of
Very good. Perfect. No. What did you forget? Can't say painless was. If you tell me painless was vision, I'll give you 5 reasons. Is it AIN? Is it NAIN? Is it CRVO? Unilateral pattern. Actually, then unilateral. No, if you tell me unilateral only, I'll give you 5. If you give me painless, there are so many.
Unilateral painless.
Unilateral painless, I can give you 5. Okay? Same. Science, critical science pannaam.
cherry red spot,
Okay.
whitening of the retina.
Okay. Plain retina, body edema. Fine. Anything else? Other signs?
Artery narrow.
Vertical narrow. Don't see and repeat. Anybody can do that. Push your brain. We have discussed everything. You guys know, even I know. Arterial narrowing is correct. Not directly. Remarks will come. Marked.
In the brain.
Box scarring. Segmentation of the arterioles. What else?
In the spreading what he did. Retinal pigment.
The edema already I level.
And the
The critical sign line. The differential diagnosis. There's one more point you guys forgot. Horenhurst plaque. Chalapo orange refractal plaque. Maybe it's coming in the management. Okay, fine. Okay, fine. Etiology fine. Fine. Critical signs, Sada signs. Next, diagnosis. వేరే ఏదో సంభవం ఇങ്ങനെ ఉండవు
acute ophthalmic
అక్యూట్ వర్డ్ అది ఓర్ముండవు
ophthalmic
ophthalmic artery stenosis ophthalmic artery occlusion మదిలే
Yeah.
acute ಇದೆಲ್ಲ ನಮಗೆ ಓರ್මුండవు ophthalmic artery and occlusion central retinal artery occlusion ophthalmic artery പക്ഷേ వేరే ఏది కండిషన్ లో చెరిగేట్ స్పాట్ ఉండవు ఓకే కమర్షియల్ రెటినా
and hay.
Human pick. Okay. Then what else? Penile back in the commercial retinal and around. Commercial retinal, binocular loss of vision.
A blunt trauma.
No, wait. Binocular loss of vision is there. Bowel edema is there. Cerebral spot is there. But always with a history of trauma is the differential question. What are the etiologies of this? At least 3 etiologies per now. Is a prakarant emboli.
Cholesterol,
calcium and platelets.
Did you say calcium?
Calcium and platelets.
Pinne?
Thrombosis.
Pinne?
And hyperhidrotic.
Three very very common sense. നമ്മൾ ഇത് മറിയൂലല്ലേ മറിക്കൂലല്ലേ ഇറ്റ്സ് വെരി ഈസി കോമൺ സെൻസിന്റെ അസോസിയേറ്റ് പോയിന്റ്സ് നമ്മൾ തീരെ മറിക്കൂല the points with for which we have not made stories for which we have not made justifications you will forget 100% I am writing it down already I am forgetting the list next 3 because the next 3 points are iffy next 3 enta ayego yeah see rare causes who the hell will remember this trauma nobody will remember so forget that. Now what you will do for these people Fatima why you want to waste time doing that
platelets
okay fine forget that but why you want to waste time for this patient doing ESM world's longest treatment why you want to waste time with this patient doing his ESM all these things
like beyond the age of 55 there is a chance of
beyond the age of 55
giants
55 mention ചെയ്യണം
yeah
ഇത് ESR എല്ലോki ചെയ്യൂലല്ലേ 55 mention
Inch.
ചെയ്യണം
Inch.
55 is the main thing if he is 55 years of age then he can have a GC okay patient 55 ಇಲ್ಲ 30 years தான் அப்ப எந்த டெஸ்டிங் செய்யலாம்
Can be meted up, right?
if patient is not 55
It
check
can
for
be
hypercoagulability state rheumatoid status check for antinuclear antibody check for syphilis treponema antibody FDA ABS testing check for the only ones that you can lipid profile The only ones with which you have associated a story only you can tell. The cerebral electrophoresis we had no story. We will definitely forget that. Hemoglobin electrophoresis okay. Coagulable state. Okay. അങ്ങനെ ചെയ്യണം. Then capital artery Doppler. Yes. What else we can do?
ECG.
To warn you about the heart effects. What else we can do? Already carotid Doppler. Huh? IVFA. Yeah. To confirm the language. Where is IVFA pinna? When you say IVFA, do you know what it means? What do you normally call IVFA? FFA or not? You sound very intelligent, but you will forget it, trust me. നീ എഫ് എഫ് പറയുമ്പോൾ ഞാൻ എന്തൊക്കെ എഫ് എഫ് പറഞ്ഞിട്ടുണ്ട് നിങ്ങൾക്ക് മനസ്സിലാവും. If you are about to understand why I am saying FFA, why did I say FFA in the class that day, I'm talking about you yourself. Why did I give that answer? You should have a basis for that. Why you are saying FFA? Where is it? അവിടെ ഏതിനാ കാരണം? എന്താണ് FFA പറയാൻ കാരണം? അവിടെ എഴുതിയിട്ടുണ്ട്, ഞാൻ ജസ്റ്റ് റിപ്പീറ്റ് ചെയ്തത്. എന്താണ് അങ്ങനെ ഉണ്ടെങ്കിൽ തീരെ you will forget it. എല്ലാവരും അങ്ങനെ തന്നെ ആണോ? സിമ്പിൾ അങ്ങനെ തന്നെ. അവിടെ ആർട്ടറി ബ്ലോക്ക് ആകുമ്പോഴേ ആർട്ടറിനുള്ളിൽ ഡൈ കയറില്ല. അപ്പോൾ പെട്ടെന്ന് നമുക്ക് മനസ്സിലാവും ഡൈ അവിടെ കയറുന്നില്ല. സോ ഇതാണ് CRAO. ഓക്കെ, അങ്ങനെ ഒരു അണ്ടർസ്റ്റാൻഡിങ് ഇല്ലെങ്കിൽ നിങ്ങൾ പറയാനുണ്ടെങ്കിൽ ഡെഫിനറ്റ്ലി യു വിൽ ഫോർഗെറ്റ് ഇറ്റ്. ഇതിൻ്റെ ഹൗ ഡു യു സേ മൈ അഷ്വറൻസ് ഇൻ മലയാളം. This is my assurance.
എനിക്ക് ഉറപ്പാണ്
നിങ്ങൾ മറക്കോ? ട്രീറ്റ്മെന്റ് അനലോഗ് ഇല്ല. Anecdotal. ഇപ്പോൾ ചെയ്യാൻ ഒരു വർഷം കഴിഞ്ഞില്ല. Next,
digital massage.
Digital means 6 മണിക്കൂർ ഞാൻ സംസാരിക്കും. അപ്പോൾ തീരെ മനസ്സിലാവും. വർക്കുള്ളൂ. What else? Fundus contact. Paper bag. Hyperreduction. Anemia. Retinal parasitism. പിന്നെ follow up എങ്ങനെ ചെയ്യാം? Follow up ആവശ്യമാണോ? ഓൾറെഡി കാഴ്ച കമ്മിയായില്ലേ? പേഷ്യന്റ് വെറുതെ very very careful about
Neovascularization of the iris and
if it is there then
TRP or
TRP and the VEGF for the
perfect.
Thank you, sir.
So next time, not next time, tomorrow. You guys need to come here at 11 and I will ask Dilna how many questions will be covered Dilna?
5 and top 5 stuff 4.
5.
Like the